Hello, Dr. Gary Swift. Thank you so much for talking to me today.
It's my pleasure, Christy.
Dr. Gary Swift, what is endometriosis?
Christy, endometriosis is a condition which affects about 8 to 10% of women. Now, what it is the normal endometrium is the layer inside the uterus that thickens up and sheds each month with a menstrual cycle. In those women who get endometriosis, those cells go back through the tubes and go into the pelvis. Now, most women have little scavenger cells which mop up that blood that goes back inside the pelvis, but a small number don't, so the immune system doesn't seem to process it properly. Those little patches of cells grow onto the lining tissue, so that's in an area called the pouch of Douglas, the pocket between the uterus and the bowel. Little ligaments called uterosacral ligaments on the peritoneal surfaces. Peritoneum's like the inside skin. Underneath the ovaries, on the surface of the ovaries, and other points inside the pelvis, and sometimes even outside the pelvis. And instead of those cells, as I said, just being scavenged and removed, they actually attach, grow, and then they respond to the hormonal cycle in subsequent cycles. So the cells thicken up, they bleed, but there's nowhere for the blood to go. So it creates a condition with progressive scarring and distortion of the anatomy inside. Now the problem is that this starts probably from a very young age.
And how does it present itself, Gary? What are the symptoms?
Look, the most common symptoms is what's called the classical triad of painful periods, painful intercourse, and subfertility. So it often starts, we see in girls, probably soon after their first period. In their early teenage years, the periods start becoming painful. And the classical thing is we'll look back and see a history of increasingly painful periods. There may be a family history, so mum or aunt or other sisters may have had symptoms as well. And those painful periods often get worse through school years. We find often young girls get put on the pill to manage periods, and often that'll take the edge off the symptoms, so it'll put things literally on the back burner through their teen years, and sometimes even in their 20s. Then when women become sexually active, sometimes if there are particular deposits inside the pelvis, then sexual intercourse, particularly deep penetration, can actually sort of hit sore spots and make sex quite uncomfortable for some women. And that could often be the marker. Sometimes that's positional, so different positions are more comfortable, some positions hurt particularly, and that can be the simple mechanics of intercourse and where the deposits are. Subfertility is probably the third most common presentation, and some women who may or may not have bad periods, but sometimes they take longer to fall pregnant, or they are presenting with sort of infertility as a primary presentation, and in those women, when we actually look inside, they're much more likely to have endometriosis than the general public, and they don't always have signs. So what we find clinically is points of tenderness on examination, usually up behind the uterus, around those ligaments, and there is a small proportion of women who have no symptoms at all. So it's a disease that doesn't correlate well between clinical presentation or symptoms and the actual findings we see when we go investigating. So there's always a small number of women who are found actually with pelvic masses with large swellings inside that subsequently prove to be endometriosis that we didn't expect.
So Gary, how is endometriosis diagnosed?
We can occasionally suspect it on ultrasounds and other imaging modalities which don't require operations, and in that scenario, they're usually the more significant sort of stages of the disease where there's what's called chocolate cysts or endometriomas inside the ovaries, and we can see them on ultrasound and they have a typical appearance. But ultimately, the gold standard for diagnosis is what's called a laparoscopy. And a laparoscopy is a surgical procedure where the woman's put to sleep, a small incision's made in the umbilicus or the belly button, and then we fill up the abdomen with gas. And then when we put a special telescope in through the umbilicus, we can actually see all the pelvic organs. And we can see, and the deposits have classical appearances. In young women, they're often clear or what's called vesicular lesions. As the disease progresses, as the time of the disease presence goes on, they're often what's called red or flame-like lesions. The older they are, they then become blue and black, and in different stages of disease, they cause sort of scarring or distortion around the lesions, as well as attaching some things together. Sometimes the ovaries stick to the sides of the pelvis, sometimes the bowel will stick to the back of the uterus. So scarring and distortion of anatomy occurs. And there seems to be a particular group of women who have a subgroup called deep infiltrating endometriosis, where there is quite a significant pelvic distortion and where it goes into the wall of the bowel, sometimes in the wall of the bladder. But all of these fundamentally requires laparoscopy to diagnose.
And once diagnosed, what are the ways that endometriosis can be treated?
Well, again, Christy, the gold standard for treatment is laparoscopic surgery or keyhole surgery. So not only do we diagnose endometriosis with a laparoscope, but it gives us the opportunity to treat it as well. Now, it's sometimes thought of as laser or cautery. There's different energy sources we use, but the goal is the same, and the goal is to actually remove the diseased tissue from inside and give the body the chance for healthy tissue to come across and heal over. So for some women, we're sort of peeling the abnormal skin off, removing deposits from the surface of the ovary. Sometimes if there are ovarian endometriomas, then we've actually got to shell them out of the ovary and stitch the ovary back together. So in young women, and of course this disease process tends to affect women, as I said, teens, 20s, 30s, so reproductive years, our primary concern is preserving normal anatomy, preserving fertility, and obviously relieving pain and discomfort. So our surgical treatments are geared to that, and removing these tissues, these painful deposits, are what gives us the best chance of cure.
How does endometriosis affect women's fertility?
Well, look, endometriosis, directly in proportion to the amount of disease, will have a negative impact on fertility. So it's a multimodal effect on fertility. So just having endometriosis in your pelvis, even if your uterus, tubes and ovaries are normal, will reduce the chance of successful conception. And we think the little chemicals or the little hormones that endometriosis deposits make interferes with both egg formation and release, of tubal transport, and of what's called implantation, or when the actual fertilised egg tries to implant. If endometriosis actually distorts the anatomy, so it actually sort of kinks or obstructs fallopian tubes or blocks ovulation because there's scarring in the ovaries, then it has a more direct effect on physically sort of blocking the sperm and egg interaction. And unfortunately, even though with laparoscopic surgery, we think with optimal surgery up to 70% of women can be cured, 30% of women will still get the disease back. So women who have endometriosis removed with laparoscopic surgery may conceive on their own, and that's our ideal target, but they also may need assisted reproductive technologies. Some will need IVF, some will need either timed uterine insemination or other procedures to help to give them a better chance of conception. And of course, the longer it takes them to fall pregnant after a surgical procedure, the more chance that the disease can come back and have a continuing effect. So, although our target is to rid women of the disease, maximise their fertility, help them conceive, we know that there is always the potential for fertility to A, be difficult, or B, even decline with time afterwards. So it's important that someone manages them who is both skilled at the diagnosis and treatment, and also can offer them the right fertility assistance at the right time in their lives. And some women are very young when they're first treated, so they're not immediately embarking on fertility. And those women, because we want to preserve their anatomy, we often use the oral contraceptive pill or sometimes hormonal methods to try and prevent any recurrence occurring until they reach the time when they do want to have children.